Good evening, everybody. Well, whilst we're still waiting for some people to start, I'm just going to make a little start here ahead. Sorry, I'm a bit befuddled this evening. Just had a collapsed patient out at the entrance to the hospital. So it sort of put the evening on a different keel than I was expecting. But anyway, here we are. Well, welcome. This is the second of our events that we have. Where Elaine is going to talk to us this evening about targeted cancer treatments and a bit about the science behind them and how they, the drugs that we're giving, and give us some background to the treatments that we're administering. So at this point, I'm going to hand over to Elaine. And thanks, Elaine. We all enjoyed. I had lots of positive feedback last week for the cancer cell biology, and the recording has gone to be edited. And when it's ready, I will then forward it on to people who were unable to attend last week. But the feedback was very positive. So at this point, I'll hand over to Elaine. Thanks, Elaine.
Okay, thank you. Just a word of warning. At some point, I think my husband will probably come through the door, at which point the small dog, currently somewhere in the house, is likely to go loopy. So there may be barking and things. I've left him treats to bribe her into silence, but we shall see how effective they are. So last week I was talking about cancer cell biology, how cancer cells operate, what drives them, how they create for themselves an environment in which they can thrive and survive. And this evening, I'm going to take that a step further and talk about some of the mutations that drive them, we can now target with various targeted therapies. So could I just, there's one person, I think Louise, who hasn't got her microphone muted. If you could just do that, can hear it? Yeah, perfect. Can just hear a bit of background noise. Okay, I will sort out the slides and share them with you. You just give me a second. I'll move things around and put my slides up and share that with you. Okay. Oops. Okay. So I can see my slides and hopefully you can too. I can also see the meeting chat. If there's any problems with the slides freezing or not being able to hear me or anything, please do, if you can't catch my attention, either give me a shout or type into that meeting chat, and just occasionally there are problems with connection. So if you just let me know if that happens. So this is what I'm going to target. Sorry, this is what I'm going to cover even. I'm reading my slide before speaking. What are we trying to target? I will spend a lot of my time on the drugs that block cell communication pathways because that's the biggest group of targeted therapies. I'm not really going to talk about angiogenesis inhibitors, just for the sake of time, really. I wanted to make sure that I mentioned at least one treatment group that didn't have a kinase target or a cell signaling target. So I thought I would say a little bit about the PARP inhibitors and also just a little bit about the stuff that we can't target, the stuff that we would like to be able to do something about and yet can't. I think sometimes we can get so dazzled by the number of drugs out there that it can be easy to lose sight of all that we can't do and would like to be able to do. So just a few words about that before the end. We'll start with an introduction as to what are targeted therapies. Now, I think it is tempting to think of targeted therapies being things that target cancer cells, but that's not really what they are. They're things that have a known target by and large, but that known target may well be important to cancer cells, but it is likely to be useful and important to some healthy cells too. So these are not treatments that are free of side effects. They have different side effects. Hopefully they have less severe side effects than chemotherapy, but they are not free of side effects, because whatever it is we're targeting is probably useful to some healthy cells too, and some of them are not maybe as precisely targeted as we would like them to be either. Another theme with these targeted therapies is that they've often been chosen or designed specifically because they block that particular target. And that's different from how the way the many chemotherapies were developed. Chemotherapies have often been developed just by scanning and testing lots and lots of different chemical structures and testing them against cancer cells and healthy cells, trying to find ones with some kind of differential and then tweaking and refining from there, but not with any real knowledge of what it is you were targeting or why it would be toxic or how exactly you go about improving it. So these have generally been, the targeted therapies have generally been deliberately designed to block a specific target. And they fall into two main groups. We have the antibody-based targeted therapies. They are based on the natural antibodies made by our immune system, but they've been deliberately designed or selected because of their ability to attach to a target found on cancer cells. They are generally incredibly precise in what they block or what they attach to, whereas the small molecules tend to be less precise, although they are more precise than what they used to be. They are tiny little chemical compounds, much the same size as a chemotherapy drug. They are created in the lab step by step through a series of chemical reactions. And as I've said, they tend to be less precise than the antibody-based therapies. These drugs have been designed to block a target, and those targets are usually involved in the hallmarks of cancer, the properties of cancer cells that set them apart from healthy cells. Now, I've tried to illustrate here just some of the hallmarks of cancer. It's not an exhaustive list. There's a couple of extras and there's enabling characteristics, and it all gets a little bit confusing. But I've listed here some of the main hallmarks of cancer cells, the features of cancer cell behavior that set them apart from the way that healthy cells behave. These behaviors of cancer cells are often driven by proteins that are the consequence of mutations in the cell's DNA. Now, I tried to explain the link between DNA and proteins and behavior last week, but essentially, if you have a fault in a cell's DNA, that is going to alter the proteins it makes. And because proteins do all the work of the cell and make stuff happen, if you've got a faulty protein, then you're likely to end up with faulty cell behavior. So each of these behaviors is driven by various different faulty proteins, some of which we are able to target with our treatments and some of which we are not. So there's some of these hallmarks that we're doing better with than others in terms of creating drugs that can target them. When I talk about immunotherapy, I will talk about the treatments that target cancer cells' ability to avoid destruction by the immune system. I've said already, I'm not really going to mention the angiogenesis inhibitors that target the blood supply. I just decided that was a step too far in trying to fit everything in this evening. I will mention the PARP inhibitors that target genomic instability, and I'm now going to say quite a bit about growth signaling pathways and the various drugs that target that particular hallmark of cancer cells. And there are an awful lot of drugs, hence why spending most of my time on this group of treatments. We have antibody-based treatments, we have small molecule-based treatments, all of which block the growth signaling pathways that are often overactive in cancer cells. And before I talk about the drugs that block these pathways, I want to explain the pathways. I think often we hear the words like the EGF receptor and HER2 and RAS and RAF and MEK and PI3 kinase and AKT, and all these names get thrown at us, or we might be familiar with a few of them, but often people don't spend time explaining the big picture of how all these things fit together. So I'll start with that first and then talk about the treatments that target these pathways. So I'll begin with the fact that all our cells have many different receptor proteins on their surface, and they use these receptor proteins to give and receive signals from one another. And one type of signal that cells often release into their environment and that they use to communicate with their close neighbors, these are the growth factors. They're small proteins. They're released by our cells. They travel short distances between cells and then attach to growth factor receptors on the surface of neighboring cells. When growth factors attach to growth factor receptors, that triggers off pathways within the cell, one protein activating another and another and another, and gradually the signal received by the cell at its surface is transmitted through the cell into the cell's nucleus and alters what proteins that cell then makes, and alters the cell's behavior. Because these pathways, because these signals have the potential to tell cells to grow and multiply, this process is normally very tightly controlled. So I'm going to go through it in slow motion a couple of times over. I think a bit of repetition is helpful. So I'll begin again with the fact that growth factors attach to growth factor receptors on the surface of our cells. And this causes receptor proteins to pair up. Once they're paired up, they have docking sites for another set of proteins, the docking proteins. And these docking proteins activate or trigger off these series of events in the cell cytoplasm that culminate in the cell changing its behavior through changing what proteins it's going to make. A third time now, just trying to layer up the detail a little. So the growth factor receptors, there's about 50 or so of them, different ones found on the surface of different types of cells. Perhaps the most famous ones being the human epidermal growth factor receptor number 1, also called EGFR, and the human epidermal growth factor receptor number 2, also called HER2. They don't tend to get referred to as HER1 and HER2. I think EGFR had just been around long enough that everybody got used to calling it EGFR before we realized there was a HER2. And in fact, there's a HER3 and there's a HER4. There's a whole family of these things. But numbers 1 and 2, we tend to call EGFR and HER2. Growth factor receptors respond to the presence of growth factors. And when growth factor receptors have grabbed hold of growth factors, they change shape. And now the two receptors can pair up. Because they've taken hold of the growth factor, they've changed shape, they now have interaction domains that link them together. Once they've paired up, they use their kinase domains. The inner portion of growth factor receptors is a kinase portion. So as well as being receptors, they're also enzymes that can cause a chemical reaction. That chemical reaction is that they take phosphate, a phosphorus atom surrounded by oxygen atoms is known as a phosphate. It's a high energy little chemical group. They can grab hold of phosphates from a chemical called ATP, and they transfer them onto each other. So proteins that act as catalysts for chemical reactions are enzymes, and enzymes that can attach phosphates to things are kinases. So the kinases are a subgroup of all the enzymes in our cells, and the enzymes are a subgroup of all the proteins in our cells. There's about 500 or so different kinases in our cells. So the growth factor receptors are just one set of kinases. There are many others. So these growth factor receptors, once they've paired up, they attach phosphates to one another, and that's why we call them, sometimes we call them receptor tyrosine kinases, because they are kinases as well as being receptors. They attach phosphates to each other, and this is what creates the docking sites for docking proteins. And when these docking proteins have attached, they can then trigger off various pathways within the cell So they can activate the RAS proteins, which activate the RAF proteins, which activate the MEC proteins, which activate the ERK proteins, and so on. You get the triggering of all these chain reactions within the cell of one protein activating another and another and another, and gradually the signal is sent through to the cell's nucleus. Specialized proteins attach to genes and they turn on the production of numerous proteins. And this whole process happens within a few minutes. Just 5 minutes after feeding a growth factor to a cell, you can see it starting to produce new proteins as a consequence of that growth factor's presence. Different cells have different growth factor receptors on their surface. Different growth factor receptors respond to different growth factors. Different amounts of growth factors attaching to different versions of growth factor receptors will have a preference for which of these pathways it activates and for how long and what consequence that has for the cell. So there's all sorts of nuances of this. In different cells, the pathways work in different ways. There's different feedback loops present. There's an awful lot of detail. But in a nutshell, when growth factors attach to growth factor receptors, that triggers off reactions within the cell that lead to changes in behavior. And those pathways in the cell are known as cell signaling pathways or cell communication pathways or signal transduction pathways. We call them a variety of different names, but we're referring to the same thing. In cancer cells, growth factor signaling pathways tend to be overactive. Cancer cells often secrete lots of growth factors. You find faulty and overactive versions of the proteins passing on the signal within the cell, like faulty overactive versions of the RAS proteins or BRAF or MEC or PI3 kinase or AKT, or proteins that normally block these pathways are missing. Proteins like PTEN or NF1 are commonly missing from cancer cells. You might also find overproduction of growth factor receptors, mopping up all that extra growth factor and just sending signals over and over and over into the cell. And sometimes the growth factor receptor is there in the normal amount, but it's mutated, it's faulty, it's overactive. So for a wide variety of different reasons, in most cancers, there is a problem with growth factor receptor controlled signaling pathways. The drugs that block these pathways, as I've said, we can split them into two categories. We have the antibody-based treatments and the small molecule-based treatments. And I'm going to start off with the antibodies. Now, antibodies all have this sort of same basic Y structure. Antibodies are made of 4 separate protein pieces, 2 big pieces, 2 small pieces, known as the heavy chains and light chains, which have been linked together with chemical bonds. The very tip of the antibodies, the 2 tips of the Y, that's what attaches to the target. So they have 2 antigen binding sites, 2 bits that attach to a target, and then the back end is what recruits in and activate white blood cells. So perhaps if you have a bacterial infection, you might see antibodies attaching to the bacteria and telling white blood cells to ingest and destroy them. Or you might find antibodies attaching to virus infected cells. And again, sending signals to the immune system saying, attach and destroy whatever it is I'm now attached to. Antibody-based cancer treatments are very versatile. They're antibodies that have been tailor-made and selected so that they attach to a target on cancer cells are very useful cancer treatments. You can decide exactly what it is you want the antibody to attach to. You can mess around with the back end of an antibody, making lots of little tweaks and changes and enhancing the antibody's ability to attract in and activate white blood cells or complement proteins or whatever it is you want that antibody to do. You can also use antibodies to deliver chemotherapy. Chemotherapy drugs are tiny little chemical compounds. You can chemically link them to an antibody without really changing the shape or size of that antibody. So you can use the antibody to deliver a chemotherapy payload. You can also mix and match antibody pieces and create strange proteins with new functions. So for example, bispecific T-cell engagers are where you've created a brand new protein, something that would never normally exist in nature, but one bit of it attaches to T cells, one bit of it attaches to cancer cells. You bring the two together and hopefully the T cell kills the cancer cell. We're beginning to do this in hematological cancers, not yet in solid tumors, but they do look promising. Also in hematological cancers, we have CAR T cell therapy. This is where a brand new gene is inserted into the patient's own T cells, forcing the T cells to produce an antibody-based protein. But it's a weird antibody-based protein because you've got just the tip of an antibody tethered into the T cell with other bits and pieces of protein. So you can do all sorts of things with antibodies and modify them in various different ways to create the treatment that you want to create. I thought I would give you an example of Herceptin. I'm sure many of you will have heard of Herceptin. Its scientific name is trastuzumab. It's a treatment for people with HER2 positive breast cancer. We also, some people's stomach cancers are HER2 positive and they might be prescribed it then as well. Herceptin is just one example of an antibody-based treatment, but I think it's quite a useful example because it's very well known. So in about 20% or so of people with breast cancer, of course, vast majority of these people are going to be women, but men can get it too, hence using the word people rather than just women. So about 20% of breast cancers, the cancer cells have extra copies of the HER2 gene. The HER2 gene has been amplified. There's extra copies of it. And because those cells have extra copies of the HER2 gene, they make extra amounts of the HER2 protein. And as I've already said, HER2 stands for the human epidermal growth factor receptor number 2, closely related to EGFR, but distinct. So breast cancer cells often have more than the normal amount of HER2 on their surface. And HER2 does what growth factor receptors do. It transmits signals into the cell using these various pathways, the Ras-RAF-MEK pathway, PI3 kinase AKT-mTOR pathway. The HER2 protein will trigger off these pathways, sending the signal into the cell, telling it to grow, multiply, and survive. Herceptin is an antibody designed to attach to HER2. So it will connect with the HER2 protein, and this seems to actually do a number of different things, but including it blocks all the signals that HER2 is trying to generate and prevents them from reaching the cell's nucleus. If that cell is relying on its HER2 to generate the signals to keep it alive and growing and multiplying, then that Herceptin antibody is going to tell that cell to die. Herceptin, because it's an antibody, can also recruit in and activate white blood cells. But as I said last week, cancer cells tend to create for themselves a really immune suppressing environment in which they're living. So although white blood cells are there, they're not generally white blood cells that are very useful and not usually ones that Herceptin can recruit. Although having said that, if there are some useful macrophages and natural killer cells around, then Herceptin will recruit them and that will help women where this can happen. They do seem to get more benefit than if it's an immune suppressing environment. So Herceptin, if the white blood cells are there, it will recruit them if it can. As well as having plain old Herceptin, we now have antibody drug conjugates versions of Herceptin. This is the Herceptin antibody trastuzumab, but now with copies of a chemotherapy linked to that antibody. And the idea here is that the antibody attaches to the HER2 on the cell surface, and it does everything that the normal Herceptin antibody does. It shuts off cell signaling, it even has the potential to attract white blood cells. But the antibody has an added dimension in that it will also get driven inside the cell or get absorbed inside the cell after it's attached to its target, with the chemotherapy still attached, and then the linker hopefully breaks, the chemotherapy is released, and that adds to the toxic effects of the antibody. So antibody drug conjugates, they are antibody therapies, but with bells on. They can also deliver cell-killing chemotherapy. And these antibody drug conjugates are getting better all the time. And who knows exactly what the future holds. It's always impossible to predict. But I feel like we had the era of maximum optimism around targeted therapies in probably the early 2000s. Angiogenesis inhibitors as well, probably maximum optimism was in the early 2000s. Then optimism waned a bit as we realized that resistance happens, that because tumors are diverse, because there is variety amongst the cancer cells, there's always cells in there that are resistant to our treatment, and pretty much always the person's disease becomes resistant to treatment, particularly if they have metastatic disease. So we went through an era of maximum optimism around targeted therapy and angiogenesis inhibitors. I have to as well, looking back in time, there were also times where people thought that chemotherapy was going to cure everything, that radiotherapy was going to cure everything. This is what human beings do. We get overexcited about things, then they have to sort of dial things back a bit as reality sinks in. So we had maximum optimism around targeted therapy and angiogenesis inhibitors in the year 2000 or early 2000s. Then over the past 5-6 years, probably a bit more now, isn't it? The first checkpoint inhibitor immunotherapy was approved in 2011, 2012, thereabouts. So we've had about 10 years now of immunotherapy with checkpoint inhibitors. And we're still really optimistic about those, but perhaps less so than we were. We're realizing their shortcomings. I think antibody drug conjugates, these antibodies with chemotherapy attached, we are just entering into an era of antibody drug conjugates. We are getting better at making them. We are creating ones that are an improvement on the ones we've had in the past. And I thought a good example would be to compare trastuzumab emtansine with trastuzumab deruxtecan. So trastuzumab emtansine is known as Kadcyla or TDM1. Trastuzumab deruxtecan is called NHER2, I think it's called, or TDX, it sometimes gets abbreviated as. So trastuzumab emtansine, Kadcyla, came first. It has about 3 or 4 copies of drug per antibody. It attaches to HER2, the membrane folds inwards, the entire thing gets drawn inside the cell, but the linker doesn't break. In order for the chemotherapy to be released, the cell has to completely digest and break apart the antibody. So this doesn't happen terribly efficiently, but drug does get released and it is highly toxic to cells and leads to cell death. And trastuzumab emtansine is useful in some circumstances, but probably I would say not as useful as researchers were hoping it would be when it was first created. Trastuzumab deruxtecan, in contrast, has 8 copies of the drug per antibody rather than 3 or 4. It attaches to HER2, the membrane folds inwards, it ends up inside the cell, but this does have a linker that very quickly breaks inside cancer cells. The chemotherapy is highly toxic. It's a topoisomerase inhibitor. It kills the cells, but also that drug is permeable, it leaks out of cancer cells and kills nearby cells, creating a bystander effect. And trastuzumab deruxtecan has proven to be more effective in trials than trastuzumab emtansine, and it can work against breast cancers even with very low levels of HER2 on their surface, and about 2/3 of breast cancers have HER2 on their surface to some degree. So instead of this treatment being only applicable if you have very high levels of HER2 on your cancer cells, it's now possibly going to become a treatment for 2/3 of breast cancers, even when there's only low amounts of HER2 on the cell surface. So trastuzumab deruxtecan, I think NICE is making a decision later in the year as to how widely to make this treatment available, whether it should be given to a wider range of people with breast cancer in the future. And that's just one example of a newer antibody drug conjugate. There are many, many others. There's so many of them coming through clinical trials with, breakable linkers, with permeable drugs, with more copies of drug per antibody. There's a lot of these antibodies coming through trials. It's there's still quite an old style, more like trastuzumab still coming through trials, as well as some of the newer ones. So it's a little bit of a mixed bag at the moment, some more effective than others. But I think over the next 5 to 10 years, we're really going to see a lot of antibody drug conjugates get licensed in a lot of different cancers. And one of the benefits of an antibody drug conjugate is you're not targeting, or you're often not targeting, the consequence of a mutation. And it seems there are fewer resistance mechanisms, so they might work for longer, perhaps, compared to some of our other targeted therapies where you are very precisely targeting the consequence of a mutation. But we'll see, time will tell exactly how useful these treatments turn out to be. Just a few examples of antibodies that target growth factor receptors that are useful as cancer treatments. There's the various ones that target HER2, ones that target EGF receptor, the ones that target VEGF or VEGF receptors. These are angiogenesis inhibitors because these growth factor receptors found on blood vessels rather than cancer cells. But just a few examples of where we're using antibodies as cancer treatments. Just a few select examples, there's many more than just these. Okay, then moving on to the small molecules that target these same growth factor signaling pathways, but now from inside the cell rather than attaching to the receptor on the cell surface. So just to reiterate, the small molecules, they are tiny chemical compounds, much the same size as a chemotherapy drug, tend to be less precise than the antibodies, usually target a protein that's inside the cell rather than on its surface. Most of them block kinases, enzymes that can attach phosphates to things. And that's because kinases have a really handy pocket in their surface where you can wedge a little drug. So they're a great drug target because they have that handy little groove in their surface. The small molecule kinase inhibitors, they always end in the letters IB, sometimes NIB, a few other endings as well, but that IB is common to them all. So these are the kinase inhibitors. They are small little chemical compounds that block kinases. And as I've said, kinases are a type of enzyme that catalyze a particular chemical reaction, and that is they attach phosphates to things. This is a very, very common way that our cells use to control their proteins and what they're doing. About a third of all the thousands of proteins inside our cells, about a third of them are phosphorylated, have phosphates attached to them at any given moment in time. So these kinases are whizzing around in our cells, attaching phosphates to things and bringing those things alive. Often attaching a phosphate is like putting the batteries into something. It suddenly springs into action with that phosphate attached. There's another set of enzymes known as the phosphatases that remove phosphates rather than adding them. And kinases have this handy little binding pocket where you can wedge a kinase inhibitor. It's the binding pocket where ATP normally fits, the kinase's source of phosphate, but you can wedge a little drug in there instead. We have a lot of different kinase inhibitors that we use as cancer treatments because kinases have two crucial properties. One, they have this handy little pocket in their surface. Two, they're often driving cell behavior and driving cancer cell behavior in particular. So drug companies are always searching cancer cells for overactive kinases because if there's a kinase, we probably can make a drug that blocks it. And I'll go back to that example of HER2 because as well as being a cell surface receptor, HER2, it's a growth factor receptor, it's a receptor tyrosine kinase. The inner portion of that HER2 protein is the kinase part of that protein. And so you can create drugs that block, that kinase part of the protein. And many of the growth factor signaling proteins, things like RAF and MEK and ERK and PI3 kinase and AKT and mTOR, these are all kinases too. They're passing the signal from one to another, telling the cell, look what just happened. A growth factor attached to our growth factor receptors will now transmit that signal through the cytoplasm and into the cell's nucleus. So we have three ways to block a kinase. We can use an antibody to block the receptor tyrosine kinases from outside the cell. We can use small molecules to block the tyrosine kinase part of the growth factor receptor from inside the cell, or we can try and block off the pathways by targeting one of the other kinases that's passing on the signal and transmitting it into the cell's nucleus. Whatever way we're doing this, we have the same goal. We're trying to stop the growth, survival, and multiplication signal from ever reaching the cancer cell's nucleus. And hopefully, if it was relying on that signal, then shutting it off will cause the cancer cells to die. As with antibodies that target growth factor receptors, we have lots of drugs that target kinases. I've given you here some of the drugs that target the kinase portion of HER2. They are mostly given to people with HER2 positive breast or stomach cancer. The drugs that target the kinase portion of the EGF receptor, these are mostly given to people with lung cancer only if the EGF receptor is mutated and overactive. If that isn't the case, then these drugs don't work particularly well and you're better off with an alternative treatment approach. But if the EGF receptor is mutated and overactive, which is reasonably common in lung cancer, then you may be eligible for one of these treatments. The BRAF protein is mutated and overactive in about a half of all people with melanoma skin cancer. When that is the case, the person may be given a combination of a BRAF inhibitor with a MEK inhibitor. They work better when they're given in combination. BRAF mutations are also found, but only rarely, in the cells of lung cancer. But again, you might give a BRAF MEK inhibitor combination. And you also find people with bowel cancer where the BRAF protein is mutated. There we use a slightly different approach. With skin cancer, if BRAF is mutated and you block it, often the cancer cells die. In bowel cancer, if BRAF is mutated and you block it, the cells survive because there's a feedback loop. You block BRAF, you overactivate the EGF receptor, it feeds down through the other pathways, the cell manages to stay alive. So in bowel cancer, we use a different combination, a BRAF inhibitor combined with an EGF receptor inhibitor, preventing the feedback loop. In some people's cancer cells, there are weird kinase fusion proteins. 2 chromosomes have broken, genes have got swapped around, you end up with the kinase portion of one protein attached to another protein, creating an overactive weird kinase protein. This is virtually always the case in chronic myeloid leukemia. You get this weird BCR-ABL fusion protein that we can block with BCR-ABL inhibitors. In people with lung cancer, sometimes you find weird ALK fusion proteins or weird ROS1 fusion proteins or weird RET fusion proteins. There's a few different ones you find sometimes in lung cancer. They are overactive kinases. We can block them with kinase inhibitors. Now, I didn't want to leave you just thinking that all our targeted therapies block growth factor receptor signaling pathways and they're all antibodies or they're small molecules that block kinases. There are kinase inhibitors I haven't touched upon. Again, just for the sake of time, I'm not trying to cover off all the treatments, but I thought it would be good to give you an example where we have a targeted therapy, but with a very different sort of a target. So I thought I would give you the example of the PARP inhibitors. To understand the PARP inhibitors, we need to know a completely different bit of science. Forget everything about growth factor receptors for the time being. I'm going to quickly give you a brief overview of DNA repair options in our cells. As I mentioned last week, the DNA in our cells is constantly getting damaged. That's a fact of life that happens day in, day out in all the cells in our body. Our cells cope with that by having lots of different options for DNA repair. For every type of DNA damage, there's a different DNA repair process, sometimes more than one. If there's just a nick to one of the strands of the DNA double helix, then there is a single strand DNA repair process dependent on the enzymes known as the PARP enzymes. If a chromosome snaps in two, that's a double strand DNA break, but cells have methods of repairing that, their preferred method being homologous recombination. Now, these are just two repair mechanisms. There's a whole raft of them, but I'm just saying there's others. Homologous recombination exists in all organisms. You know, sea slugs have it. It's not just found in human cells. It is an incredibly efficient and accurate way of repairing broken chromosomes. And if a cell's chromosome breaks, this is its preferred method for repairing that break because it's so accurate. But it involves an enormous number of proteins all working together to affect that break. In ovarian cancer, we know that roughly a half of ovarian cancers cannot perform homologous recombination. Sometimes it's because the woman has inherited a BRCA gene mutation. Sometimes that BRCA gene mutation has occurred just in her cancer cells during her lifetime and isn't elsewhere in the body. Sometimes it's another mutation affecting another homologous recombination gene that's the problem. But if you take a woman with ovarian cancer and examine the ovarian cancer cells, about half the time you're going to find some problem with homologous recombination. It's a little bit messy. We're not sure of all the consequences of the mutations we find in ovarian cancer cells, but we can do various different types of testing to find out which cancers are homologous recombination deficient, sometimes abbreviated to HRD. And we know that when cells can't perform homologous recombination, they are rather unstable. They're likely to pick up a lot of mutations, they're likely to have all sorts of problems, and they're likely to have a lot of problem repairing any further DNA damage that they sustain. And they become very, very reliant on single strand break repair mediated by the PARP enzymes. If you expose cells that already can't perform homologous recombination to PARP inhibitors, you are going to kill those cells. They're already having difficulties because they can't perform homologous recombination. Now, if you add to their difficulties by adding in a PARP inhibitor, they accumulate so much damage so quickly that they just fall over and die. So it gives us an opportunity for treating people whose cancers are deficient in homologous recombination. We know that PARP inhibitors shouldn't really affect their healthy cells too much because our cells have so many different DNA repair mechanisms that they can draw on. So healthy cells shouldn't be too badly affected. But if the person's cancer cells can't perform homologous recombination, they should be sensitive to treatment with PARP inhibitors. So the idea is that a healthy cell, you expose it to a PARP inhibitor, it does have a few problems. You do see the accumulation of DNA breaks because it can't repair single strand breaks. That has knock-on consequences. It leads to double strand breaks. But so long as homologous recombination is intact, the cell will be fine or should be fine. But if it's the person's cancer cells and they have a defect in homologous recombination, then expose those cells to a PARP inhibitor, you get the same accumulation of double-strand DNA breaks. The cell has no accurate, efficient way of repairing those breaks. So hopefully what happens is the cells then die. PARP inhibitors are important treatments for ovarian cancer. This has happened in the last few years, that we now have several different PARP inhibitors. Olaparib was the first to be created, but there's niraparib, there's rucaparib, there's talazoparib, there's veliparib, there's a whole bunch of these angiogenesis inhibitors. Their main use at the moment is in the treatment of women with ovarian cancer. They can extend survival a long time. There are women who are free of disease many years later, having received chemotherapy for their disease and then receiving maintenance treatment, follow-up treatment with the PARP inhibitor. And until very recently, the NHS had only approved PARP inhibitors for the treatment of ovarian cancer. But just earlier this month, I've just taken a screenshot here that on the 6th of April this month, NICE decided that actually there was sufficient evidence, and crucially, the manufacturers had brought down the drug cost sufficiently that they decided that actually people who've inherited BRCA gene mutations and have developed either breast cancer or prostate cancer, those people would also be eligible to receive a PARP inhibitor as part of their therapy. So as of this month, PARP inhibitors are now licensed not just as treatments for ovarian cancer, but now also some people with breast cancer or prostate cancer. And then the final thing I wanted to mention was just about what we don't have. I've talked so far about all the things that we do have and the things that we can target and the things that we can do, but I just wanted to emphasize, I suppose, that there's a lot that we can't do that we wish that we could, because some of the most common mutations found in many cancer types that drive their behavior, some of them are just really hard to target. For example, the PI3 kinase AKT-mTOR pathway, it's activated by growth factor receptors. It's also activated by a bunch of other receptors on the surface of our cells. And it's a pathway that's very commonly overactive in cancer cells, either because of mutations affecting PI3 kinase. So the PIK3CA mutations affect the activity of PI3 kinase. Loss of PTEN also leads the pathway to be overactive, and they are very common mutations. But we have numerous problems. One is that these pathways are activated, or this pathway is activated by a lot of different receptors. It's used by an awful lot of healthy cells to perform healthy functions. So immediately you have a problem in that if you target the pathway effectively, you're going to cause a lot of side effects, because they're involved in such a wide range of different things, including insulin growth factor receptors, that they control blood sugar levels and cause all sorts of problems when you block this pathway. Also, because the pathway is so important and used by so many different cells for so many important functions, there's lots of redundancy and lots of compensatory pathways. So when you try and block this pathway, often you don't achieve it because the cell has workarounds, because it's important and it doesn't want it to be blocked. So although we have a large number of drugs that can block PI3 kinase, that can block AKT, that can block mTOR, in a lot of clinical trials, it is touch and go whether they work out to be useful enough to get approved as cancer treatments. In many trials, you see pretty low numbers of patients benefiting and a lot of toxicity. Just occasionally, there are circumstances where it is worth blocking a PI3 kinase pathway or AKT, but a lot of the time, the trials have been done and it's turned out not to be a useful strategy. Another protein commonly overactive in cancer cells is the RAS protein. So there's three main RAS proteins, KRAS, NRAS, and HRAS. about a third of all human cancers contain overactive versions of RAS proteins. The problem with RAS proteins is that they are not kinases. Because RAS proteins are not kinases, we've had real difficulty trying to find ways to block them. Indirect targeting doesn't seem to work, so it's been tried where RAS mutations have been discovered to go, okay, well, RAS is mutated, so maybe we'll block off RAF, or maybe we'll block off MEK, or maybe we'll try blocking off PI3 kinase. But that indirect targeting generally doesn't help. There's just too much crosstalk. You know, if you block one RAF protein, RAS just feeds through to a different RAF protein, or you block off PI3 kinase and the cell uses a different workaround. So indirect targeting of the RAS proteins doesn't seem to help. If you try and block the RAS pathway and the PI3 kinase pathway simultaneously, you often get really awful toxicities, because these pathways are both important to lots of healthy cells as well as to cancer cells. We do now have some glimmers of hope in that the first ever KRAS inhibitors have now been approved as treatments. However, these RAS inhibitors only block KRAS, not NRAS or HRAS, and they only block one specific mutant form of KRAS. We have these two drugs, sotorasib and adagrasib. They block the G12C mutant version of KRAS, and they actually interact with the cysteine. So G12C says, okay, the 12th amino acid, the 12th building block in the KRAS protein ought to be a glycine amino acid, and instead it's a cysteine amino acid. And these drugs actually bond, chemically fuse with that abnormal cysteine and manage to block this KRAS G12C version. But the G12C version of KRAS is pretty common in lung cancer, but very, very rare in other cancer types. So although this is a glimmer of hope, and hopefully it will be followed by other RAS inhibitors, so far we just have these two drugs that block one mutant KRAS protein. And then another mutation that's very common that we would love to be able to do something about are the TP53 gene mutations. P53 mutations, or TP53 is the gene, P53 is the protein made from that gene. TP53 mutations are the most common mutation found across human cancers. Our problem is, though, that TP53 is a tumor suppressor gene. P53 is a tumor suppressor protein. So what happens is, if our cells sustain damage to their chromosomes, that triggers P53 protein levels to increase. When P53 protein levels increase, they cause the cell's mitochondria to release their stores of a little protein called cytochrome C. And cytochrome C activates a bunch of enzymes known as the caspase enzymes, and they chop up the innards of the cell and destroy it by a process called apoptosis. So P53 is a tumor suppressor protein. It protects us from cancer. It triggers faulty cells with DNA damage to die. So what we would like to be able to do is restore P53, but we don't know how to do that. It is much easier to block an overactive enzyme than to replace something that's missing from cells. How would you do that? How would you get that protein into every single cancer cell and tell them all to die? We have no way of doing that. There are efforts to try and take advantage of the lack of P53. There's a few different strategies being explored, but at the moment, these TP53 mutations, the most common mutation across human cancers, we can't do anything about. And something I've alluded to a couple of times, and something I mentioned last week, is that one thing that thwarts and is the weak point of all our targeted therapies is the way cancer cells behave and what drives them and how they evolve. cancer cells are often driven by multiple coexisting mutations, not just a single mutation that we can target with a single treatment. And once cancer cells have arisen, they don't just stay as they are, they gradually evolve and diversify over time. So you get pockets of cells with new mutations that are resistant to whatever treatment you prescribe. So we do see resistance and relapse when we give people with advanced cancer a targeted therapy. Often it works for a time, but then the cancer regrows. And also, cancer cells live in a very complicated environment full of other cell types and blood vessels and white blood cells and fibrous proteins. And there's lots of protection and resistance mechanisms that aren't to do with the mutations the cells contain, but the environment in which their cells live. So targeting a single mutation or a single process is rarely enough to kill every last cancer cell in a patient's body, especially if they have advanced disease. It can help, them not saying targeted therapies aren't worthwhile, because clearly they often can help a lot. And if they are used as a neoadjuvant or adjuvant treatment, then we may be curing people with our treatment. But if we are giving these treatments to people with advanced disease, then they are likely to work for a while, but they're not going to work forever. So finding a mutation isn't the end of the story. We need to know what type of cell the mutation is in, because different mutations have different consequences in different cancer types. And I mentioned the example of BRAF mutations in melanoma versus bowel cancer. You can give a BRAF inhibitor MEK inhibitor combination in melanoma, but you need a different combination, a BRAF inhibitor with an EGF receptor inhibitor, as a combination in bowel cancer. In addition, we need to know exactly what mutation it is we're talking about. In lung cancer, we find numerous different EGF receptor mutations, some which create sensitivity to EGF receptor inhibitors, some create resistance to those same drugs. So we need to know exactly what the mutation is before acting upon it. Different mutations also have different consequences. Often, if a mutation creates an overactive version of a protein, that is a better target and you can get better results and longer lasting results from patients than if it's just that the cells make extra quantities of the normal protein. So a point mutation is generally more likely to be worth targeting than gene amplification or protein overproduction. Different sorts of mutations have different consequences for the cell, and therefore that alters whether a targeted treatment is likely to be effective or not. And the degree of variation amongst the pockets of cells in the person's tumor correlates with how long treatment is likely to work for. Melanomas and lung cancers in people with melanoma skin cancers in people with a history of sun exposure, and lung cancers in smokers, they tend to be very heterogeneous. There's lots and lots of pockets of cells with different mutations inside them. When you give a targeted therapy, generally it really doesn't work for very long. The situation is different. Lung cancer in non-smokers, much less complicated disease, targeted therapy is likely to work for much longer. You also get heterogeneity such as we see in stomach and gastroesophageal cancers. These cancers are often HER2 amplification positive, but when you look at the cells in the tumor, some cells are positive and some cells are negative. It's not even throughout. In HER2 positive breast cancer, you tend to have a more uniform presence of HER2 on all the cancer cells. Stomach and gastroesophageal cancer, it's more patchy. So there's different types of heterogeneity and variation, but it all causes problems when we come to trying to match mutations with targeted therapies. So hopefully I've provided a useful insight into some of the targeted therapies we give to people with cancer. Targeted therapies are treatments that have been designed or carefully selected so that they target a protein or a process that we believe is important to cancer cells more so than to healthy cells. But you're still going to get side effects if they're not actually that precise, or if their target is actually still enormously important to healthy cells as well. You are then going to get side effects. The vast majority of targeted cancer treatments are either monoclonal antibody therapies or they are small molecule kinase inhibitors. The antibodies are large proteins. Their target is always something on the cell surface, even if they get driven or absorbed inside the cell later, the target is on the cell surface. The mechanism of action of an antibody depends on how you made it. Are you trying to shut off a growth factor signaling pathway? Are you trying to recruit in white blood cells? Are you delivering chemotherapy? Are you attacking the cancer's blood vessels? The mechanism of action will depend on what antibody you've chosen and how you've modified it. The kinase inhibitors, most of them target kinases involved in cell signaling pathways, such as the growth factor receptors on the cell surface, or BRAF or MEK or BCR-ABL, ALK. These are all kinases. Another set of kinases that I haven't mentioned are the CDK inhibitors given to some women with breast cancer. Again, just for the sake of time, I decided I couldn't include everything. As well, I haven't mentioned the kinase inhibitors that target angiogenesis. Small molecules with targets that aren't kinases, well, there aren't many of them, but PARP is a good example. The PARP inhibitors, important treatments for many women with ovarian cancer, very recently approved as treatments for some people with breast or prostate cancer. Resistance to targeted therapies is pretty much inevitable, particularly if the person has advanced cancer. Resistance is usually happens because there is variety amongst the pockets of cancer cells within the person's tumor. Cancer cells evolve, they diversify over time. You get pockets of cells with additional resistance causing mutations that survive treatment and cause the cancer to return. And that means targeted therapies precision is also their greatest weakness. We are trying to create drugs precisely targeted towards the consequences of mutations. But the degree of variation amongst cancer cells means that they are, because of their precision, unlikely to kill all the cells in a person's tumor, whereas something like chemotherapy, a bit toxic to any cell that's multiplying. So a very different, more general mechanism of action, but can be helpful. If there's a cancer with a lot of heterogeneity, then chemotherapy might be helpful, or something like checkpoint inhibitor immunotherapy that I'm going to cover next time. But it's 7 o'clock. Gosh, time flies. Anyway, so I shall stop there.
Thank you, Elaine. That was fantastic. It was good to get that overview. And when you talk about the eras and of optimization, having done SACT delivery in some shape or form for 30 plus years, I find it, I can remember the excitement in the 2000 with Herceptin. And now we move on a bit and we've got, I haven't learned to pronounce the word yet, but trastuzumab deruxtecan. And I suppose I just wonder, if there will be a role for that in the upper GI cancers where you have less HER2 molecules. But just before you answer that, if anybody has any questions, do you want to write your question in the chat box, please?
Where the chat box?
Or to ask, or
you
even
can
just
speak.
ask now.
I mean, I've no problem with people speaking.
Yeah.
If that's easier.
Yeah.
I can't see the chat box.
Don't worry, just ask it out loud.
Yeah.
Jacqueline, just ask the question out loud. If it's
you.
you.
Sorry, you can hear me.
Yeah, we can.
Hear you.
Just ask out loud.
No, I was just wondering because I missed the first session last week.
And I was wondering if you would send out the recorded video about it.
We're just having it edited, and then once it's done, I've got your name, Jacqueline. So for anybody who missed last week's, I can forward them on the link details when we have it ready. And the same with this session. So if you have any colleagues, tell them to email me. Yeah.
I've sent through a PDF of the slides as well.
As
so
well.
You're welcome to have those too.
Yeah. So just, I was wondering, like, I think with these new drugs, it's good to, you know, as in day-to-day practice, we're seeing them all being used in combination. I hear your dog has decided.
I know, I think my husband, she can recognize his car, so I presume his arrival is imminent.
Yeah.
A quick question. You know, the drugs that was mentioned on the websites, because I'm sort of newly qualified and I haven't seen some of them in the wards. Does that mean certain drugs are only licensed to certain trusts?
No, what I would say is depending on which hospital, what specialities you do. So for example, olaparib, which is licensed in ovarian cancer, and we've been using for a couple of years in ovarian cancer. As Elaine just said, it's just had it nice, just approved it for use in prostate breast cancer. So you'll start to see it moving into those areas in the next several months, I would say. And then I think it will depend whether the drugs are oral, what their toxicity profile is like. So you may not be seeing them much on the ward, but over time they will start to come in more and more.
Thank you.
Often there's more than one drug for any given target.
Yeah.
Sometimes they, you know, one supersedes another, like with the EGF receptor inhibitors. Alotinib and gefitinib came first, and then we got afatinib and dacomitinib, and they were a little bit more potent. Now we've got osimertinib, and it's superseded them all, and mostly it's just osimertinib we're given. So sometimes there are improvements over the years, the drugs get better. Sometimes it's just that multiple drug companies have all created very similar drugs, and they put them into different clinical trials in different disease areas because they're all trying to find a marketplace for their drug. So there's several different PARP inhibitors, there's several different CDK inhibitors. There's no massive difference between these drugs. It's just different drug companies wanting to get in on the action. And then it really depends on what clinical trials have been performed and what data has been put forward to NICE, and when you could end up with different drugs ended up being used in slightly different circumstances. So you might come across one and not another. So it will just vary depending on what disease areas you're working in.
And I think somebody there, rituximab, a bit like Herceptin, they're two what we'd consider now old drugs. They came out in the early 2000s, late 90s, early 2000s, and are still being used. And I'm not sure there's anything out there that's overtaking rituximab, Elaine, is there, for
Not
the
really, I
hematology?
think,
No.
because rituximab was created, I think, in 1992.
Yeah.
So it's about 30 years old now. And various drug companies, they've had a good go at seeing if they can better it. It targets a protein called CD20. It doesn't really kill cells outright. It recruits in white blood cells. Various companies have tried to improve on rituximab, but you put them into head-to-head trials, and rituximab generally holds its own. Nothing has really bettered it. So we still use it because it's still a good option, and combine it in different ways with some of the other targeted therapies. I haven't really mentioned the targeted therapies for hematological cancers. I do a whole study day on them because they're different than the solid tumors. I'm sorry if people are hematology specialists and haven't heard their favorite drugs mentioned, or I don't know, drugs that they're hoping to hear about. It's just the targets are different, the mechanisms are different, the drugs are different. I can't possibly fit it all into one presentation, so I haven't said much about the hematology agents.
Lovely. Thank you, Elaine. Have we any other questions, please? Okay, with that, Elaine, thank you very much. You're free to log off now. And just to tell everybody that the next session we have with Elaine is on immunotherapy with checkpoint inhibitors, and that's on the 17th of May at the same time. Okay.
Yeah, lovely. See some of you then.
Thank you. Thanks,
Cheers.
Elaine. Bye.
Bye.
I'm going to stay on and do a quick 10-minute session on just anemia management in reference to iron deficiency, and it's due to some work, a project that I've been involved with over the last few years in particular. I will just find. So if those of you who want to stay on, please do. And if anybody has to go, that's fine. As I said, this session will be recorded and will be made available at a later date in the next week or two once we get it edited.
Okay.
Yeah.
Thank you.
Yeah. All right. And just before people go as well, is just to say that the next session is on the 17th of May, and that will be looking at immunotherapy with checkpoint inhibitors, and there will also be a short presentation by Emma Earnshaw as well. So over the next 10 minutes, as I say, I'm just going to talk about anemia and iron deficiency in oncology and hemato-oncology adult patients undergoing SACT. And it's a bit of work that we did. It started several years ago with the primary aim of trying to reduce the number of blood transfusions. But in doing so, it was actually that we would then check patients for iron deficiency and treat appropriately. So just a quick few points. Anemia in cancer patients is quite often at the point of diagnosis. About 39% of our patients will be anemic, and according to World Health criteria, World Health Organization, then that is where in men it's where the hemoglobin is less than 130, and in women it's where it's less than 120. As patients go through treatment, be it surgery, radiotherapy, or SACT, then the incidence of anemia increases to 67%. And in the general population, as well as those with cancer, the causes are complex, and iron deficiency is the most common cause. And the symptoms that patients will complain of is fatigue. Think about how many times do we meet our patients, talk to them, and fatigue is the common problem. It impacts on quality of life. It makes just answering the front door more difficult. It impacts on performance status, and indirectly how patients cope with their treatment. So treatment of anemia, the various options we have is the normal go-to one is we check is the patient if they're anemic, can we give them a blood transfusion? Iron replacement therapy is becoming more commonplace. In the past, we've used maybe oral iron, and patients have had issues around tolerating that, and I'll come back and go through that in a little bit. And then there are another class of drugs, the erythropoietic stimulating agents, which we use less in cancer care, even though the European Society of Medical Oncologists would recommend their use, but they are commonly used in renal conditions. As I said, red cell transfusions are the most common way of treating anemia, but the benefits are transient, they don't last, and yet the risks and the time and resource implications are extensive and far outweigh the benefits of a blood transfusion. And really what the ESMO guidance from 2019 recommends is that for confirmed iron deficiency, intravenous iron is a more appropriate means of treatment. So just quickly, here is a list of why iron is important. We need it for oxygen transport, for our metabolic processes. And then we have the ways we store iron. So when we're looking at storage of iron, we're looking at our ferritin, and hemosiderin levels. When we're looking at the transport, we will look at transferrin saturations. And the important regulator, a hormone called hepcidin, is important in the movement of iron throughout our body. So when hepcidin is upregulated, that means our iron isn't being moved across from our gut into our system as much as we'd like. And when it's down regulated, then it allows for the ease of iron absorption. Now, there's lots of debate about how do we measure iron deficiency, and the most acceptable way, and certainly in accordance with the ESMO guidance at the moment, will be to look at it, the transsaturation, and have it less than 20%, and look at the serum ferritin level. You're not looking at the serum iron level, you're looking at the serum ferritin level, and this is less than 100. And we have two types of iron deficiency. We have functional iron deficiency and absolute iron deficiency. So functional is when there's a problem with the mechanism in iron moving around our system as we need. And this is generally common or assumed to be the most common cause of iron deficiency in patients with cancer. Cancer causes inflammation, it causes our hepcidin levels to rise, and therefore doesn't allow for the ease of absorption of iron. Where absolute iron deficiency is where there's been a problem. Is the individual bleeding a lot? Have they had poor nutritional intake of iron, and therefore both their TSAT and their serum ferritin levels are low? So just to give you a little idea of trying to understand what iron deficiency does to the system, here we look and you can see the storage of iron and our transport of iron around our bodies. And on the left hand side, you'll see that the people's hemoglobins are normal and we've got a good store of it. But as we go through iron depletion, gradually our stores of iron start to deplete, yet our hemoglobin and our remains normal. The next stage is our hemoglobin is still remaining normal, but we've lost more iron. And gradually, when we get to iron deficiency anemia, we then ultimately start to have a lowering of our hemoglobin. And this is a process that doesn't happen necessarily overnight. It can take place over a period of time, and as a consequence can take a lot longer to recover. And so the PREVENT study was a study done here in the UK. The results came out just around the time COVID started, and what it showed, they tried to give patients who were having moderate to major surgery where blood loss is known, and rather than what they would do, they gave everybody an iron infusion with the aim that it would reduce blood transfusions in the first 30 days post the surgery. However, it didn't do that, but what they didn't correctly do is identify which patients were iron deficient. And when they did do a sub-analysis and looked at those patients, they actually then went on to find out that those patients had less complication rate in the 6 months post their surgery. Overall, whilst it didn't change things for those first 30 days, it didn't reduce their time spent in hospital, but it reduced the number of patients who had to have a secondary admission because of a complication due to the surgery they had had. So there is a definitive role to look here at checking for iron deficiency and the impact it has. And iron deficiency does make patients symptomatic. So we started doing some work on this back in 2017. We've gradually introduced guidance and gradually audited, redone training, and it's an ongoing piece of work. But currently, this is our guidance, and for all patients who start SACT, we check, regardless of their hemoglobin, we will check their TSAT and their ferritin. And if one or the other is low, i.e. less than 20%, or the ferritin is less than 100, we look at giving the patient one single IV infusion of iron. If the patient is anemic, but then they're not iron deficient, we then go on to check for vitamin B12 and folate deficiency. And if that comes back as low, we refer them to their GP for replacement therapy. And our aim is that we only consider the need for a unit of blood transfusion if the TSAT and the ferritin levels have been checked and are corrected. In accordance with our own trust guidance here in Oxford, and it will, I believe this will be on a national level, we really should only transfuse patients if their hemoglobin is less than 70 and if their symptoms require urgent action, such as bleeding, myelosuppression, cardiac compromise. So we've been working with these guidance now for a year, and we do this, we do it in oncology, and we introduced it into the hemato-oncology, so patients with lymphoma, in the last year. And just to say, like, we did an audit in March 2022. We showed in the top box here, you'll see about 90% of our patients have been tested. I think what we were surprised with our findings is that about 50% of our patients will suffer with some degree of absolute or absolute or functional iron deficiency. And it was actually the amount of patients who suffered with absolute iron deficiency. We had an assumption it would be mainly functional. And here you can see in the bottom graph where we started off with doing no iron infusions in 2017, and we're up to now where we do about 40 to 50 per month. Likewise, our results in March of last year for blood transfusions, where we were doing 40 to 50 blood transfusions per month, we have actually decreased it down to about 10 per month. And all of our patients in March of last year who had a blood transfusion had also been checked for iron deficiency, and if they were iron deficiency, 100% of them had had it corrected. So what's some feedback we've had from patients who have been received an iron infusion? And some, like one lady I remember meeting, and she thought her fatigue was due to her chemo, but she was on a long-term maintenance therapy and she was about to stop it because she couldn't cope with the fatigue anymore. And I remember us talking, and we did checked her iron levels, and she was iron deficient. She had an iron infusion, and actually her fatigue symptomatically improved so much that she stayed on her chemo. We do offer the iron infusions on the same day as chemo, and patients have come back with I've got lots of stories, but it's too late in the evening to tell you them all now. So why overuse IV iron? It overcomes the effect of hepcidin. This is the hormone that controls the absorption of iron. It will depend on each of your own trusts as to what you do. We more commonly use the Ferinjet, which is ferric carboxymaltose. IV iron is more effective than oral iron for our patient group, and for having a quicker reaction to it. It's well tolerated, but it's not without its issues. You need to check for allergies and make sure the individual is not pregnant, make sure they don't have an active infection, and check for comorbidities such as asthma, rheumatoid arthritis, gout. It's not necessarily that you can't give it, we just need to have be aware of it and maybe slow down the infusion. And you can give IV iron on the same day as a blood transfusion. As I've mentioned, some of the risks, one is of extravasation. It's a brown drug. It looks rusty colored when it's made up, and it can cause permanent staining. For some people, this may not be a problem, but it is a contraindication that you would need to advise patients about. And Pharingetin itself can cause hypophosphatemia. I'm not going to go through all of this now. If anybody wants me to do a teaching, I can come back and do a more detailed teaching on another date. So to conclude, our nurse-led service has shows that the testing for ID increased from 0 in 2017 to 90% in 2022. It also highlights the prevalence of anemia and of iron deficiency within our patient group. We've also increased the number of iron infusions, and we've also decreased the number of blood transfusions. And it's all about equipping our staff, educating our staff and our patients on iron deficiency anemia. So our work is to continue to educate our staff and embed the guidance. And we actually have a further audit underway, which we hope to present will be available in the next 2-3 months. That is all I'm going to say for now. Thank you. Does anybody have any questions? No, I don't see any questions coming in.
Ask her something, she'll be disappointed.
Oh, hello. Sorry, I can hear somebody. Hello.
Sorry, that was my husband telling me to ask you something.
All right. Okay.
Otherwise, you might be disappointed. It was a very good presentation.
It was a very quick presentation, and I just like just to say I'm conscious of the time.
Kate Reeves won't be on at you then for overrunning.
Oh, if anybody wants me to talk any more about iron deficiency anemia, I'm happy to do it on a separate session. I think what I've learned this week is that every hospital within our network has had problems of whatever. I think in Reading you've had electrical failures. For us in Oxford we've had 5FU issues, isolators breaking down elsewhere. So I think with that I will say to you all, hang up, enjoy the rest of your evening, and we'll see you on the 17th of May. But if anybody would like me to talk more about anemia at another day, we'll organise a separate. Maybe when I've got the newer audit results, we can do an update then. Thank you.